We see normal infarcts and SOLs with CT scan, all right. We can see them better. But we see a special situation which we call substentorial situation, signs, like cerebellum and brainstem, much better. So infarcts that we couldn't see in the CT scan, in the brainstem, we can see now with MRI. With the spaceochromal lesions that we couldn't see in the CT scan, like in the brainstem, like the cerebellum or cerebellopontine angle or stellar or suprasellar signs, we can see with MRI much better. Right, so just quickly, this is again right middle cerebral artery territory infarct. This is flare sequence, hyperintense in flare, white lesion in flare. So we see lesions mostly white or hyperintense in flare and T2 and hypointense in T1 or white, black. This is a branch infarct on the left middle cerebral artery. But this is something, or this is again left cerebellar or superior cerebral artery territory infarct. We could see all these three with CT scan, all right. But this is something special that MRI can see. This is T1, this is T2, this is DWI, and this is flare. And can we see mid-lobe oblongata? We can see a white lesion in the right mid-lobe oblongata, here, here, much better, here. I'm not sure. Can you see that? This is small.
Yes.
Can you all see this?
Yes.
It's small. It's difficult to see from behind, and with all these lights, if the lights were off, we could see them better. So there is a lesion, small lesion in the right side of the medulla that will give rise to clinical condition called lateral medullary syndrome with everything you know. This is again a lesion in the right side of the pons. Small lesion in the right side of the pons. You can see much better here in DWI. This is a right pontine infarct. Will give rise to right pontine syndrome. Right. So hemorrhages in the MRI, not very ideal to see in acute stage. CT scan is the investigation of choice. But MRI can detect old hemorrhage for the rest of the life very nicely. So after 2 weeks of suspected hemorrhage, we should do MRI action, not CT scan. And we can see this is a hemorrhage in MRI. And we can see this is T2 weighted, this is flare, and this is T1. And can we see it's all white and black, a mixed intensity lesion, even in T1. We don't see normal lesions like infarct or SOLs as white in T1. We see only black in T1 weighted images. But in case of hemorrhage, we see mixture of white and black. So this is an old hemorrhage. Old because there is no pressure effect. There is no much edema there. So this is an old hemorrhage, quite a few years ago. So is this one. We can see all sequence, T1, T2, flare, DWI. All there is mixture of black and white lesion with no much edema around, no much pressure effect. This is an old hemorrhage. And we can see the acute hemorrhage as well as black and white, mixture of black and white, mixed intensity, but we see a lot of edema around it and pressure effect. So this is acute intracerebral hemorrhage in MRI. Right. Spaceochromal lesions, we see neoplasms, primary and secondary, again tuberculoma or abscess. As we see before, this is meningioma, left frontal, as we saw in CT scan, tissue enhanced, nicely enhanced tissue, black, enhanced, attached to margin. Again, multiple ring enhanced shadows, tuberculoma, metastasis. But we see, especially in subtentorial sites, this is a space called cerebellopontine space, or CP angle, on the right side, on the left side. This is cerebellum, this is pons. This is T1, black lesion, contrast enhanced, T2 and flare. We can see there is a lesion in the cerebellopontine angle, pressing pons and cerebellum. This is a CP angle tumor. Okay? Agreed? This is again another one. I just flipped the MRI from right to left just to show you the similarity. This is again a CP angle space-occupying lesion between pons and the cerebellum. Let's say so on the right side as well. CP angle, two lesions are common. One is called vestibular schwannoma or acoustic neuroma, and another is meningioma. And we can predict or presume what one this is from just its appearance. Can you see there is an angle, there is a conical projection on the right border of this lesion. This is called ice cream cone appearance, like an inverted ice cream cone ice cream. If this angle, you can see this angle or projection or ice cream cone appearance, this is very likely to be acoustic neuroma. But unlike this one, can you see here, there is no cone and it's smooth, the outer margin is smooth. This is very homogeneously enhanced. This is likely to be a meningioma rather than acoustic neuroma. But it can also be others like diamorphis and so on. So these are two examples of acoustic neuroma. If you are given the possibilities, I would press acoustic neuroma or vestibular schwannoma as number one in this case, and meningioma as second. I will place meningioma here as first, and vestibular schwannoma as second, to get the full marks. Right, this is a special one, not very common, bilateral acoustic neuroma. And you can see the ice cream cone appearance on both, symmetrical on both sides. This is almost diagnostic of a case called neurofibromatosis type 2, the central type of neurofibromatosis. Can present only with bilateral acoustic neuroma without any cutaneous appearances, as in an NF1 like neurofibromas and café au lait and so on. Right, this is a primary neoplasm within the pons. We can see this is not in the CP angle. The CP angle is clear. The lesion is within the pons. This is a pontine glioma, a serious condition, very difficult to operate on. Right. These are two examples of space-occupying lesion within the cellar and supracellular region. Both are very nicely enhanced. This one very homogeneously, this is less. But can you see this one extended both in cellar and supracellular region, large one, irregular, and tissue enhancement is almost homogeneous. But this one is rounded with inhomogeneous tissue enhancement. This is an example, very likely, of pituitary adenoma. And this one is probably a craniopharyngioma that has extended up into the cellar, down into the cellar region. So both are possible. First is pituitary adenoma, and second is craniopharyngioma. I would put this one as craniopharyngioma first and pituitary adenoma second. And this one as pituitary adenoma first and craniopharyngioma second. As I said, to get the full marks in exam. Right. This is a very uncommon one, and we can see this is a flare sequence. We have got all the sequences here. These are multiple cysts in all over the brain, everywhere you can see, even in the cerebellum. So these are multiple cysts, and we can see there is perirelational edema. This is a classic example and almost diagnostic of neurocysticercosis. And this is proven neurocysticercosis. And these are active because there is perirelational edema. So active neurocysticercosis. Very dangerous condition. Patient comes with all the features of raised ICP. Headache, vomiting, all over the places, and also convulsing with seizures. Right. Now, very important in case of MRI, demyelinations of the brain and spinal cord as well. I'll show the spinal cord later on. Demyelinations of the brain. Important because we cannot actually see anything or understand as demyelinations in CT scan. If it is demyelinations, you're going to have to need MRI and MRI. And different types of demyelination we'll see today. First is inflammatory demyelination, like multiple sclerosis, acute disseminated encephalomyelitis or vasculitides, osmotic demyelination, both central pontine myelinolysis or extrapontine myelinolysis, toxic demyelination, hypoxic ischemic and demyelination. Right. You can see in both situations there are multiple small T2 weighted white lesions. These are exclusively situated in the white matter and in a periventricular, mostly in periventricular situation, right? But can you see in this one, oval, perpendicular to the lateral ventricular wall and closer to ventricles. This is a bit away from the lateral ventricles in a situation called gray-white junction. Can you see? But more or less similar. Both the examples in this situation, we consider only 4. Number 1 is multiple sclerosis, and always number 1 multiple sclerosis in this situation. But the second, consider vasculitides as well, and also neurosarcoid and CNS lymphoma. These are the 4 conditions can give rise to a similar kind of MRI picture. But in this case, as this is oval, perpendicular lateral wall, and closer to ventricular wall, I would consider MS first. And others like vasculitides and CNS lymphoma and neurosarcoid later on. In this case, probably, classically, situated in the gray-white junction, probably we'll consider vasculitis first, MS, but it's all right if we consider MS first as well, and others later. Inflammatory demyelination. The second example is acute disseminated encephalomyelitis. This is flare sequence, white lesions. Can you see lumpy lesions, big lesions, well circumscribed but irregular, different shapes, situated bilaterally. Some are confluent, but exclusively in the white matter, but extending the gray matter as well. This one, lump, big lumps, bilateral. This is a condition called acute disseminated encephalomyelitis. Very dangerous situation. Patient becomes very toxic, presents acutely with fever and seizure, and quadriparesis, and whatnot. This is central pontine myelinolysis. A classic lesion in osmotic demyelination syndrome, sudden correction of sodium and all. A white lesion in a flare sequence, T2 and flare sequence, and black in T1 in the center of the pons. Patient presents with quadriparesis. This is bilateral basal ganglia lesions, symmetrical. T2M flare, hyperintense. In this situation, we consider extrapontine myeloneuritis in osmotic demyelination syndrome. So EPM in ODS, possible. But other causes are as well possible, like encephalitis, like ischemic, hypoxic ischemic encephalitis, like toxic encephalopathies, can cause bilateral basal ganglia lesion. Okay? This is that other patient that we saw with osmotic demyelination and central pontine myeloneuritis. And we can see in full picture, the patient had extrapontine bilateral basal ganglia lesion as well with CPM. The patient with CPM and EPM in ODS. Right. This is midbrain, T1 hypointense, T2 and flare hyperintense. In the posterior part of the midbrain, there is white lesion, symmetrically bilateral. And this site is called tectal plate. So demyelination or white lesion in the tectal plate. This is again a site for extrapontine myeloneuritis, but also of toxic demyelination, also of hypoxic ischemic demyelination. One thing I forgot to mention, this condition, bilateral basal ganglia hyperintensity, as I said, can be EPM in ODS or toxic or hypoxic ischemic encephalopathy, but can also be a condition called Leigh disease. So Leigh disease or Leigh syndrome. It presents with primary optic atrophy and many others clinical features. So that's all about MRI brain. Okay, we are on time. So this is MRI spine, my last topic today. And we commonly enter, by the by, for MRI, for spine imaging, neuroimaging, MRI is the choice. We cannot do CT scan in spine, we cannot see anything. So MRI is the investigation of choice in spine lesions. And we commonly see this prolapse. We are not much interested here, but that is the commonest cause probably. We see Cary spine or Port's disease of the spine, space-occupying lesions, both intramedullary and extramedullary, and inflammatory lesions, as I said, transverse myelitis, multiple sclerosis, and also spheridiomyelitis. Right. When we see MRI, we see as segments. We don't see whole spine together. We cannot actually. We cannot image the whole spine together because they are in different planes. So we divide whole spine in three segments. One is cervical segment, one is dorsal segment, and the other is lumbosacral segment. We start with lumbosacral segment because probably that is the commonest done MRI, in my experience. I'm not sure about the statistics, but probably lumbosacral spine MRI is the commonest done MRI of the spine. And we do those mostly for prolapsed lumbosacral discs, causing a lot of problems like lumbago and lumbago sciatica and a lot of problems. And it's not very academic MRI, but just to show you, this is L5 and this is S1 vertebrae, and we see a disc between L5 and S1 that has prolapsed into the spinal canal. And in axial section, we see the disc has come from the left side. So this is a left-sided prolapse number 5th, 4th and 5th and S1 lumbar intervertebral disc prolapse. Probably it will give rise to left-sided lumbosciatica. And so is this one. This is also L5S1 and from the left. But can we see here, this is T1 and this is T1 contrast enhanced, coronal and axial. We can see these two vertebrae, which is 5, 4, 3, 2, 2 and 3 lumbar vertebrae, there is markedly reduced intervertebral disc. The disc margins are irregular, and we can see there is lesion, black lesion that has taken contrast, not just in the vertebrae, but also in the tissue around it. Enlarged here. And this is an example of Pott's disease of the lumbar spines. This is more common in dorsal spine. We'll see in dorsal spine as well. But this can happen in lumbar spine. Right. Next, cervical spine. After lumbar spine, the second commonest done MRI of the spine is cervical segment. And this is a disc prolapse between 3 and 4 cervical vertebrae, causing marked compression of the spinal cord. And we can see the white spinal cord has become, so black spinal cord has become white. And this is what we call signal chain, which means there is significant compression and damage to spinal cord. And this patient will present with progressive, probably progressive, upper cervical myelopathic features. Right. This is a space-occupying lesion. This is T2 and T1 white, T1 black, T2 white, and contrast enhanced. Where is contrast? Don't see any contrast here. So this is T2 weighted. Can you see there is a cleavage between the lesion and the spinal cord? There is a fold, a cleavage, a gap between the lesion and the spinal cord. And if you get that cleavage, this is certainly an extramedullary lesion. So it's outside the spinal cord. There is a gap between the lesion and the spinal cord. Extramedullary space-occupying lesion. Spinal extramedullary space-occupying lesions, practically two. One is neurofibroma, another is meningioma in the spinal canal, but outside the spinal cord. And sure, why it became black, green suddenly. Right, so this is extramedullary space-occupying lesion, and if we see in the axial plane, it has come from the right side. So this will give rise to a progressive upper cervical myelopathic features as well and requires surgery. This is a similar, another example of extramedullary lesion and coming from the right. Right as well, coming from the right. Oh, sorry, this one is coming from the left. This is a contrast enhanced. This is another example of either meningioma or neurofibroma. Looking at it, meningioma should come first. I'll show you neurofibroma. Neurofibroma is much bigger and characteristically lobulated. And this is rounded and much homogeneously tissue enhanced. So probably this is meningioma, but keep it in mind, can be a small neurofibroma as well. Right, this is neurofibroma. Can you see T1 hypo? Sorry, this is T1 hypo. Much contrast enhanced, bigger, lobulated, And in axial section, we can see it has extended through the intervertebral foramina outside the spinal canal, giving rise to a characteristic feature called dumbbell appearance. So you have the balls of the dumbbells and the handle in the between. So that's dumbbell appearance. This is almost diagnostic of neurofibroma. Right. This is intramedullary spacocoagulation. So contrast enhanced, can you see? A bit elliptical, but marked peripheral enhancement. Peripheral enhancement. There's none there. There is no gap between anywhere. So this is an example of intramedullary spacocoagulation, either ependymoma or astrocytoma, probably. Right. Now interesting. This is hyperintense lesion. T2 hyperintense lesions. But can you see there are multiple white lesions, a very small segment, 1 or 2 segments of the spinal cord, and multiple. This is a multiple sclerosis lesion, demyelinating lesion. Can be either multiple sclerosis or a part of ADEM. Part of ADEM. So this is myelitis, inflammatory demyelination. Unlike that one, can you see the similar lesion, but it's much elongated, single lesion. It has involved more than 2 segments of the spinal cord. And this is another inflammatory demyelinating lesion or myelitis, but this is unlikely MS or ADEM. This is likely to be classical post-viral transverse myelitis that we see. Right. This is syrinx. We can see long segment, hypointense or black in T1, white in T2. 2 examples, black in T1, white in T2. And it involved from the cervicus spine, lower down, long segment. And this one has involved the lower part of the brainstem as well, gone up the foramen magnum. So these are syringomyelia, along with syringobulbia here. And we can see here, the tonsil is okay. This is tonsil of cerebellum. It remained up above the foramen magnum. But can we see it has gone down in this example? This is example of Arnold-Chiari's malformation with tonsillar herniation, syringomyalgia, and syringomyelia. This is another example of Arnold-Chiari. Much herniation of tonsil, lower down, and syringomyelia. Right. So probably the last part, dorsal spine. As I said, Pott's disease commonly occurs in dorsal spine. And we can see joint space much reduced, irregular, and there is lesion in the vertebra, perivertebral soft tissue, involved with the spinal cord as well. So this is classic example of MRI in the case of dorsal Pott's disease. This patient, Pott's disease of the dorsal spine, along with perivertebral abscess. Can we see? Outside the vertebra, there is huge collection of fluid. This is perivertebral abscess, or also known as cold abscess. Right. This one, we can see multiple lesions of the vertebra involving the spinal cord as well. These are multiple metastases of the spine, dorsal spine. This is a neurofibroma, as I said, T1 hypointense, T2 hyperintense, lobulated. outside the spinal cord, but compressing the spinal cord a lot. Neurofibroma of the spinal cord. Right, so that's all I wanted to say. Hopefully I am on time. So in summary, I would like to say, CT head is interpreted as hyperdense white and hypodense black lesions. The white lesions are acute hemorrhage and abnormal calcifications. The black lesions of the brain are infarctions, SOLs, and old hemorrhage, as I said so far. Common lesions in MRI brain are infarcts, hemorrhages, ICSOLs, and demyelitic lesions, as in MS, edema, and ODS. Common lesions in the MRI spine are disc prolapse, Port's disease, myelitis, SOLs, and syrinx. So in conclusion, dear audience, reporter, dignitaries, students, neuroimaging is a vitally important tool for the diagnosis of various neurological disorders. These are required for many medical emergencies such as patients with impaired consciousness, status epilepticus, meningitis, stroke, and a paraplegia, quadriplegia. Similarly, CT and MRI are also important for the diagnosis of many chronic medical and neurological conditions, including headache, epilepsy, ataxia, MS, and various spinal cord disorders. Clinicians, especially internists and neurologists, are the right persons to interpret the neuroimagings because only they can correlate the findings clinically. So it shouldn't depend on the reports because they haven't seen the patient, we have. So with that, I'd like to thank you all for patience hearing. Thank you.
Thank you for excellent presentation, and I think you all enjoyed the session, very exciting. And this is the time for question and answering session. If you have any question, you can feel free to question to the speaker.
But don't ask any difficult question, please. So no questions.
So if you have no questions, we will go to the next momentous giving ceremony, and I would like to...
Just one word. There are two differentials of no questions, you know. First one is you understood, all of you understood everything. And the second one, you understood now, nothing. Right, okay, go on.
So I would like to welcome Professor F.M. Siddiqui sir to giving the memento to our honorable speakers.
Before I give the memento, I must say that we worked together in Dhaka Medical College for several years at early part of this, I think 2002, 2006, and we used to have a clinical meeting session regularly, weekly clinical meeting, and we had excellent time exchanging our views and visions, and I was completely taken away by his presentation. I cannot thank much him for recapping me as well. So it was a learning session also for me. Thank you, Mansur Habib, for being here. Yes, that's the one important thing I must say. Yeah, and because that time medicine experts do not used to take the emergency patients. They used to give all the stroke patients to us, and they will come next morning to give us valuable advice. That's how it goes. Anyway, we enjoyed together being colleagues. Thank you for being here